Hello everyone, I'm Emily Welch. I am the new supervising physician for BLS care in Whatcom County. I'm coming to you today with some training about one of our new skills for our paramedic providers and some education for our EMT providers regarding buprenorphine. This is a really cool medicine that we're adding to our ALS capabilities, but it's also something, if you're at the BLS level, that I really want you to know about because it's something that's well offered in our community, and the ER is starting to provide this medicine for our patients once they get to us. So it's something that you need to be aware of, and hopefully this will help you. So in order to introduce that, I've brought on a very special guest today. This is Dr. Bosted. He is a family physician in the county, and he also is the medical advisor to Whatcom County's opioid response. Thanks so much for joining us today.
Glad to be here.
Yeah, so why don't we start off, I feel like we're hearing a lot about buprenorphine, in the news, in the county. Why don't you tell us a little bit about, what's the hype around it and why we're so excited to have this new skill?
So buprenorphine is a really safe medicine that is used for the treatment of opioid use disorder. And in the acute setting, the thing we worry about, of course, with opioid use disorder, the really life-threatening thing is an overdose. So you will give people naloxone pretty frequently in the course of your regular care.
Very frequently.
And now, if someone has had an overdose, they feel terrible, sometimes the worst they've ever felt in their whole life. So giving them a medication to treat that symptom so that they don't feel so terrible, it makes them much more likely to continue with care. So it's a safe medication, it treats the symptoms that the person is having that's causing a lot of discomfort, and it can save their life by reducing the risk of further overdose even after a single dose.
Yeah, and I think that's a huge point, that just even a single dose can drastically reduce someone's risk of dying of an opioid overdose.
Yeah.
So, can you give us a little bit of background on buprenorphine, how it works, and what makes it kind of an exception of the opioid medicines that makes it good for treating this?
Yeah, sure. So, buprenorphine is classified as an opioid, and all opioids affect the body by binding to the opioid receptor. And that action is what leads to the reasons that people use opioids. So it can cause, pleasure, can reduce pain, but also it can cause respiratory depression and lead to death. Now, buprenorphine has pretty unique properties that make it a much safer option. So it binds very strongly at the opioid receptor, but it doesn't cause the same kinds of intoxication or respiratory distress, and can even work to help people avoid overdose if they are exposed again to fentanyl.
Yeah. So basically it comes in and it kicks off all of the other more dangerous opioids that would produce the respiratory depression and require Narcan. And it kind of builds a little brick wall there to protect all of the receptors from fentanyl while it's in your system. So It makes it a lot harder to overdose if you've taken buprenorphine recently.
Yeah. And that's actually a really good point because, as we said, buprenorphine binds very strongly. So if someone is taking other opioids, it can pull those other opioids off, and that can make someone feel really sick, similar to how they are after they've had naloxone, which also pulls all the opioids off. But, so you're in a unique position because a person has had naloxone, and at that point, they are much more likely to be sensitive to any other opioid. So if they go out and use fentanyl again, it's much more likely that that could be a life-threatening event. If buprenorphine is given, then that dramatically reduces the risk of respiratory depression.
Yeah, so it's a great tool to protect people both in the short term and in the longer term if they choose to stay on that medicine, it sounds like.
That's right.
So the next thing I want to talk about is we have this tool, and I think a lot of you have heard at this point that the ER is starting to do buprenorphine initiation once people get to the hospital. Why are we so excited about bringing this into the field, like pre-hospital into EMS care?
Yeah, so what we know is that the sooner people are exposed to buprenorphine after a naloxone reversal, so an overdose treatment, they're much higher likelihood that they are going to stay engaged in treatment in the long run. So I think about it as a really time sensitive condition. So you can think about other conditions that are very dangerous that you respond to. So you can think about it as like cardiac arrest, like time to balloon. That's really a good way of thinking about it, because the sooner you can get this medicine on board, the sooner it starts to stabilize the patient and it starts having these positive effects that we discussed.
Yeah, and I think another point is that many of you have probably had this experience where folks who get reversed from an opioid overdose feel so bad that a lot of times they're not going to want to come hang out at the ER.
Right.
And if we look at the data, a lot of EMS agencies around the country have been using buprenorphine for a little while. So when we look at the data, we see it's like 40% of people don't even go with transport once they receive Narcan.
Yeah.
And so 40% of these folks that are receiving Narcan from a near fatal overdose, or potentially a fatal overdose, are not going to the emergency room. So even if the ER is giving buprenorphine initiation and referrals and things, we're still missing 40% of people. But you all are in the position where you're contacting these people that we'll never be able to necessarily get to. So it's kind of a unique thing.
Yeah.
Yeah.
Yeah, it's pretty special.
So you've had this experience for a little while prescribing buprenorphine in the outpatient setting. I think a lot of the concern for every provider that's doing this is, how do I even approach this conversation? Like, do you have any tips of initial things to say to the person, or some phrases that you use to start this conversation?
Yeah. I think one of the best things to do is really try and recognize what they're going through and let them know that you kind of have some sense of the depth of kind of their misery in that moment, and just the recognition that you're treating them as though they're a human being. There's someone in your life who is ill, and that can go a really long way. The fact that you now have a tool that can really help them in that moment, rather than kind of traditionally you haven't had the tools, so everyone that's in that moment is not having a good time because they're sick, and they're sick kind of in a way that affects their behavior, and they may not be the most pleasant time of their whole life. They may not be great to work with for you, and that can make everyone feel kind of bad about the situation. But if you have a tool that can change the dynamic, and it can let them know that you care about them as a human being, and that you are trying to help them.
Yeah, and I think it's important to kind of state that the goal of putting buprenorphine on our trucks and getting it out into the pre-hospital setting is, one, to help people get into treatment, but really the main thing is protecting people from that next overdose, like you said. So just getting a single dose will make people much safer than they were before they contacted you, as long as the buprenorphine is in their system. And that period right after they overdose is kind of their highest risk for another potentially fatal overdose. So even getting that single dose in will help reduce their fatal overdose risk by pretty high percent.
Yeah, 70% within the first 3 days, and at 1 year, it's, if someone stays engaged in treatment and takes the medicine that entire time, it's a 50% reduction in risk of death.
So those numbers are way higher than a lot of different interventions that we do. For example, out-of-hospital cardiac arrest, we train that constantly, all the time. It's a huge thing. And it's less than 10% of people that survive out-of-hospital cardiac arrest. We're talking about a skill that we can train and provide that leads to 70% risk in the next 3 days. We can bring that risk way down just with this one skill and this one medication. So this is a huge thing that we're able to offer. All right. Any closing comments?
Yeah, a couple of things. One is that people may not want to engage in treatment right at that moment. They may not want to take the medicine. They may not want to transfer. But every time you save their life, they're going to be that much closer to maybe getting on a path of recovery. I am fortunate enough to see a lot of these people who have gone through the process. Unfortunately, many people in the acute treatment world, they're seeing people at like the worst day of their whole life, and then maybe it becomes this revolving door where they're having the worst day of their life every day. And I get to see people when they start to come out of it. And I can tell you that they can have one overdose, they can do well for a while, then they fall again, they have another overdose. But each time, if they're protected, the likelihood is stronger that they're going to be able to rejoin our community, become good family, good friends, I think it's a really valuable thing and a really important thing that you're going to be able to offer your patients.
Yeah. And even if you are not a paramedic provider that has this medicine immediately available, if you are an EMT working out in the county, this is a conversation that you can have with your patients, even if you can't immediately give that medicine, because, hey, we can go to the ER, they can get you started, they can get you a bridge prescription to get to the clinic so you can get on this medicine. It may not work every time, but when it does, this is something that works really well and does save lives. So thank you very much, Dr. Bosted, for your expertise in this matter. Next up, we're going to talk with some of our providers about the actual protocol so you guys can have an idea of what that looks like. And then we'll talk about what happens to patients after they go through this process and how they get referred to the county resources.
Hello, I am Caleb Crockett. I'm a paramedic with Bellingham Fire, and I've been working on the protocol committee for the last year. I'm here to introduce two new protocols to you. The first is opiate withdrawal, and it corresponds with our buprenorphine medication page. We'll start with signs and symptoms of opiate withdrawal. These are widespread. There's a complete list in the protocol. Some highlights are restlessness, anxiety, excessive sweating, nausea, vomiting, muscle, bone, or joint discomfort. We do have an optional COWS score, Clinical Opiate Withdrawal Scale. This helps you to quantify all of those widespread signs and symptoms and provide a numerical value. Scores greater than 5 are highly indicative of opiate withdrawal. You are not required to document a score, but it can be helpful to help you work through some of these patients. Going into BLS care, I want to emphasize that the EMTs are going to play a very important role with these patients. You're likely to be the first medical provider on scene with this patient. You may be the only medical provider that the patient sees. For starters, we want to get contact information from the patient if possible. Many of them will not want to provide you with any information at all. If you can, document a phone number, an address, or a current location or their typical location. That can be as simple as asking, are you going to be around this area for the next couple of days? Is it okay if we have someone come out and follow up with you? If you're concerned with opiate withdrawal, then recommend transport to the emergency department. The hospital is going to be the best place to meet their needs in the immediate term. They can provide medication such as buprenorphine or others, and they can plug the patient into resources. Patients are not required to consent to long-term care. They're not required to commit to getting off of opiates. This is simply to prevent them from harming themselves, repeat overdosing in the immediate future. If the patient refuses transport, many of them will, then provide leave home Narcan. We're going to provide you with a list of medication-assisted therapy clinics, or MAT clinics. These are places that provide medications such as buprenorphine, methadone, and counseling. Many have walk-in hours, and they're easy to call and schedule an appointment with. Going into ALS care. ALS providers, you can offer buprenorphine to these patients. You can explain that this will immediately help with their withdrawal symptoms and get them feeling better. And they're not committing to long-term care. This is an immediate fix. We do have a suggested script within the protocol because it is new. There's some example questions that can be helpful with screening patients and who's going to be a good candidate for medication. Your first dose of medication, we want to pre-medicate with Zofran per protocol. Prevent any further nausea and vomiting, and make sure that they actually can take the buprenorphine. Give them a sip of water to moisten their mucous membranes, and we're going to start with 16 milligrams SL or PO. After 10 minutes, you can do a reassessment and see if their symptoms are improving, worsening, or resolved completely. And then we have the option for another 8 milligram follow-up, SL or PO. This can be done concurrently with transport to the emergency department. It can also be done for patients that are being left on scene. We want to have a low threshold for buprenorphine administration because it is going to reduce the number of repeat overdoses and deaths, and we're going to hopefully immediately resolve patients' symptoms. Contraindications. Patients have to be over 16. They can't be pregnant. They can't have used methadone in the last 48 hours because of the long half-life. They're at a high risk of precipitated withdrawal. Altered mental status, hypoxia, pre-existing respiratory depression, potentially from their opiate overdose. They may need more Narcan. We don't want to give buprenorphine for mixed overdoses, including other drugs, alcohol, benzodiazepines, etc. You don't want to give buprenorphine to patients who have a severe medical illness such as sepsis. After the medication, again, continue or begin transport. If the patient's refusing, again, we want to give Narcan to leave at home. I'm going to give you back to Dr. Welsh. She's going to go into more follow-up.
Thanks so much, Paramedic Crockett, for walking us through the protocol, and hopefully you learned something with Dr. Bosted earlier. I just wanted to come by and give a couple last points here. So first of all, don't worry, there will be a pilot process. This is going to vary depending on where you work, but my goal is to have a few crews pilot giving buprenorphine in the field and work out some of the kinks that are inevitable in a new process before we roll it out to everybody. Also, community paramedics are going to be a great resource for this process, but I want to be clear that this is something that all of our paramedics and our ALS providers can give in the field. So while they can be used, we want to make sure that our patients have access to buprenorphine even when they're not available. So another point is documenting the patient's address, phone number, and their name is very, very key to getting follow-up. I know we talked about it earlier, so I won't belabor the point, but that's the only way that we can find these folks and help them get to the treatment they need later on. So make absolutely sure, if nothing else you take away from this video, that we're documenting how we can find these folks and follow up. And I'll tell you why. The Whatcom County Health Department has hired an opioid response specialist. His name is Gordon, and he's excellent at his job, to go actually follow up with these people within 72 hours. He can't do that unless we have their information. So, but his goal is to go find these folks after we get their permission to send his information to him, and then go actually offer them treatment, offer them housing resources. If they have other mental health or substance use disorders, he can help them find treatment for that as well, and then get them into programs that can help them be successful in the long term. He actually follows them up at 1, 3, 6 months, and even sometimes a year out. So this is a really helpful thing that we can do for these patients that we only get one chance to interact with, but he has the opportunity to interact with over a long period of time. They actually sent us a flow chart of what happens with the health department, so let's go through that now. So once you interact with the patient in the field, you get their consent. And that's probably just going to be a checkbox and image trend that you got verbal consent from the patient along with their regular old signature that they would sign on the PCR regardless. And then that information, how to contact the patient, their name, their phone number, and their address will be sent over in a separate dashboard to the opioid response specialist. From there, they try to contact the patient within 72 hours, and they'll keep trying if that's not the case. So they'll try to call them, they'll go to the address that they were last known to be at or their home, and they'll try their best to get in contact with the patient to refer them to resources. Now, ideally, what they want to build for us is something to get that data back to us so that we can know whether or not they were able to contact the patient and what resources they were referred to, so we can see if we're successful in this. Now, they're going to talk to the patient once they've had some chance to recover from their initial EMS encounter. They're going to explore their interest in seeking substance use treatment or any other resources they might need to be able to get them in a better place. And they're going to connect them. Now, they can do all kinds of stuff from here. They have lots of care management and case management resources to help with things like housing, food, mental health disorders that may also be contributing to the patient's difficulties, and substance use disorders across the board, not just opioid use disorder. So if they need alcohol detox or other things, they can refer from there. And they can also, which is really cool, provide transportation or even provide somebody to accompany patients to these appointments to make sure that they're able to get there and that they're able to absorb the information and get the best out of these kind of treatments. And then the part that's really cool that we don't get to do in EMS as much is they get to follow up. So they try to contact the patient again at 1, 3, and 6 months after their first contact. And they're continuously reevaluating what that patient needs. So if they lose housing, if they lose access to food, they can resupply them with those needs as they're going. And they can help with job connections, all those kind of things, as well as continuing on their opioid use disorder recovery treatment pathway. So this is why this is really important, that we get people documented and we get people referred. And this is why you all are going to be so important in this process, because it all starts with that first offer of buprenorphine or that first offer of treatment. It may not work every time, and frequently it doesn't work every time, but when it does, there's some really, really great resources and a really strong possibility that we can help somebody out and change their whole life. So thanks so much for tuning in, and I'll see you out there.